Greetings and welcome. My name is Brad Monk. I'm at Florida Cancer Specialists and Research Institute. I'm also an advisor to the GOG. I'm an advisor to Sarah Cannon Research Institute, and I wanted to bring you up to date about a program that we've been working on for more than 3 years. And why would I do it now? Well, on March 31st, there's a press release that I'm going to talk to you about, and the agent that we're interested in is relacorilant. Relacorilant is a selective glucocorticoid receptor antagonist. It blocks glucocorticoid response, and that is important because that's probably a mechanism of drug resistance, particularly in platinum-resistant recurrent ovarian cancer. Interesting idea, Monk. Well, it's an interesting idea because in a phase 2 trial published in the Journal of Clinical Oncology by Nicoletta Colombo, it suggested that an intermittent dose, it's an oral agent, was better than a continuous dose. And because it blocked glucocorticoids, you couldn't give it with dexamethasone. And the most active agent without dexamethasone is albuminated nab-paclitaxel, which you know is Abraxane. And that's equally effective to weekly paclitaxel. And the fact that it doesn't have cremophore makes it even better tolerable. So 3 years ago, we decided to do it, and we decided to do it with the GOG, SCRI, and ENGOT. So the GOG Foundation and ENGOT have been working together for years. And we do two types of trials. We do a head-to-head comparison, drug A versus drug B, or we take a medication and we do a +1 design. So both medications are in the arms, and then we do a +1 design, so 2 drugs versus 1. We do that particularly in situations where the single agent, the investigational product's not very active, such as immune therapy in PMMR, non-MSI endometrial cancer. We add it to lenvatinib as an example. We add it to chemotherapy, or bevacizumab, we add it to chemotherapy. So that's what we did. We took relacorilant and we added it to nab-paclitaxel versus nab-paclitaxel again in the highest unmet need, platinum-resistant recurrent ovarian cancer. Why? Because if the patient responds to chemotherapy, she can live probably for a very long time, and patients do. But when you become chemotherapy platinum-resistant, the patient is in dire straits. And we have only ever won twice. Bevacizumab, AURELIA, and then a study that I'm very proud of, MIRASOL. MIRASOL was a head-to-head, one medication, okay? Mirvetuximab soravtansine versus physician's choice chemotherapy. AURELIA was a +1 design, so you can do either one. We did a +1 design. Nab-paclitaxel versus nab-paclitaxel relacorilant in 381 patients, which is called ROSELLA, or if you're an ENGOT site, OV72, or if you're a GOG site, 3073. And why am I talking to you? Because there was a press release on March 31st, which shows that you can help patients live longer and live better. You can take the most active weekly taxane, nab-paclitaxel, and add relacorilant to it. And you can have a 30% reduction in time to progression. Now, it's not the median, the curve morphology, the median is not very big, okay? You take the 5.5 progression-free survival and you increase to 6.5 months. The aha moment, though, is that you have an equal impact on survival. An increase from 11.5 months to 16 months, 4.5 months of overall survival for a patient that has very few options. That's a drop the mic. That's what gets me on this communication. That's what gets me fired up for patients. It makes me very emotional. And we're going to keep moving. We're going to present it at an upcoming scientific meeting. We're going to publish it hopefully in a very high impact scientific journal. We're going to submit it to the FDA and bring it to the clinic. And this is a study that you did, that we did with our European friends and our Asian friends together. And then we're going to keep moving, right? What we do is we add it to other agents. We're going to do, and it was released on their website on April 7th, a study called BELLA. BELLA is nab-paclitaxel bevacizumab plus relacorilant, a triplet. And we're going to study it in earlier lines of therapy, and other tumor types. We're going to do what we always do. Think of it. We had chemotherapy in ovarian cancer. We had anti-angiogenics in chemotherapy. We had PARP inhibitors in chemotherapy. We had antibody drug conjugates in chemotherapy. And you guys were wondering what was next. Glucocorticoid receptor antagonism. So stay tuned. I'm excited. And we'll keep pushing together as a team to help patients with recurrent ovarian cancer live better and live longer. Thank you for your attention.